Hello, my name is Esther Oliva, and I am a hematologist at the Grande Ospedale Metropolitano in Reggio Calabria, Italy. I will be summarizing the data for emerging therapeutic strategies for patients with high-risk MDS. Then I will recall the data for emerging treatments for patients with newly diagnosed acute myeloid leukemia who are unfit for intensive chemotherapy. And finally, I will discuss advances in risk assessment and treatment personalization for patients with high-risk myelodysplastic syndromes or acute myeloid leukemia. So let's go on to the summary of the data for emerging therapeutic strategies for patients with high-risk MDS. As we know, despite therapeutic advances, high-risk myelodysplastic syndromes continues to have a poor prognosis with a 5-year survival rate of only 31%. The current treatment aims for high-risk myelodysplastic syndromes is to delay disease progression so that we can prolong survival and improve or maintain quality of life. There has been progress made in identifying genomic features for myelodysplastic syndromes and acute myeloid leukemia and understanding the immune and inflammatory mechanisms involved. So for this reason, we have some emerging treatments that reflect the research in this area. Venetoclax, which is a BCL2 inhibitor, plus hypomethylating agents, is one of the most promising combination treatments for high-risk MDS. However, we're still awaiting phase 3 data. CD47 is expressed on the leukemic cell or blast, and it inhibits phagocytosis and T-cell immune responses against tumor cells. Magrolimab blocks CD47, promotes phagocytosis of malignant cells, and promotes anti-tumor T-cell immunity. And it has demonstrated clinical activities in myelodysplastic syndromes and acute myeloid leukemia, and is still being evaluated in clinical trials. In a phase 1b study of patients with previously untreated high-risk MDS receiving magrolimab plus azacitidine, 95 patients with intermediate high or very high-risk myelodysplastic syndromes received magrolimab intravenous priming dose 1 milligram per kilogram on day 1 and on day 4, followed by 30 milligrams per kilograms every week or biweekly as maintenance. Azacitidine 75 milligrams per meter squared is given on days 1 to 7 of each 28-day cycle. Primary endpoints include safety and tolerability and efficacy in terms of complete remissions. So patients had a median age of 69. Most patients were high or very high risk. A quarter of patients had a TP53 mutation, and poor risk cytogenetics was in 62% of the patients. The median number of cycles received was 6. So these are the responses: complete remissions in 33%, and an overall response rate of 75%. 2-year overall survival was 77% for those patients that went on to receive stem cell transplantation. For those who did not, the overall survival at 2 years was 34%. The common treatment emergent adverse events were constipation, cytopenias, nausea, diarrhea. An infusion-related reaction occurred in 25% of patients. Very few were grade 3. The expected on-target anemia was manageable with priming dose mitigation and transfusion support, and the 60-day mortality was very low, 2%. In patients harboring a TP53 mutation, the median overall survival was 16 months, whereas those that did not have a TP53 mutation, median overall survival was not reached. So magrolimab is well tolerated, promising efficacy in patients with untreated high-risk MDS, including those with a TP53 mutation. PD-1 inhibits T-cell immune responses against tumor cells, and sintilimab blocks PD-1 and reinvigorates anti-tumor T-cell immunity. Here we see the phase 2 single-arm open-label study investigating efficacy and safety of sintilimab plus decitabine for newly diagnosed high-risk MDS patients unfit for intensive chemotherapy. 52 patients received decitabine, standard dose 20 milligrams meter squared days 1 to 5, plus sintilimab 200 milligrams intravenous on day 1 and on day 22. Each cycle has a duration of 42 days. The maximum number of cycles is 8 cycles or until unacceptable toxicity, progression, death, or withdrawal of consent. Primary endpoint was the overall response rate. Secondary endpoints include safety and survival. So the overall response rate was 62%, which included 29% complete remissions, and there was also hematological improvement experienced in 19% of the patients. The common grade 3 treatment emergent adverse events were febrile neutropenia and pulmonary infection. There were no grade 4 treatment emergent adverse events, nor treatment-related deaths reported. Half of the patients experienced immune-related adverse events, which were all resolved with glucocorticoid treatment. So these preliminary results demonstrated that sintilimab plus decitabine in patients with untreated high-risk MDS is safe and has some clinical activity. Now, TIM3 is expressed on immune cells and also on leukemic cell blasts, and it is not expressed on hematopoietic stem cells. TIM3 on immune cells suppresses anti-tumor immunity, and the interaction of TIM3 and GAL9 on leukemic cells promotes self-renewal of leukemic stem cells. Sabatolimab inhibits the self-renewal of leukemic cells and promotes anti-tumor immunity. There are 4 clinical trials that are evaluating sabatolimab for high-risk MDS. One of the randomized trials has been completed in April 2022, and the data is not yet available. Randomized double-blind placebo-controlled phase 3 trial is evaluating also sabatolimab in CMML. There's also a triple combination, sabatolimab, azacitidine plus venetoclax for high-risk, intermediate, very high-risk MDS. This is a single-arm phase 2 trial. And then there's another trial in the US for sabatolimab plus investigator's choice of hypomethylating agent. So to summarize, magrolimab plus azacitidine was well tolerated with promising efficacy in patients with untreated high-risk MDS, including those with TP53 mutation. Preliminary results demonstrated that sintilimab plus decitabine in patients with untreated high-risk MDS had manageable safety and clinical activity, and there are 4 ongoing trials investigating sabatolimab in combination for high-risk MDS in patients who are ineligible for intensive chemotherapy or stem cell transplantation. So now we can move on to recall the data for emerging treatments for patients with newly diagnosed acute myeloid leukemia who are unfit for intensive chemotherapy. So patients with newly diagnosed acute myeloid leukemia who are ineligible for standard induction chemotherapy can be really challenging to treat. They may harbor high-risk features, cytogenetic and molecular features that lead to chemoresistance. Some patients will have a poor performance status, meaning that treatment cannot be tolerated. And so despite the availability of many emerging therapies, many elderly patients will still receive palliative care. So patients may be ineligible for intensive treatment if considered unfit and or elderly, and so there is an unmet need. Now, lower intensive therapies such as hypomethylating agents are widely used. They are more tolerable, but they have a very reduced efficacy. And so emerging therapies for older patients with newly diagnosed acute myeloid leukemia are, for instance, oral azacitidine, venetoclax, FLT3 inhibitors, IDH1/2 inhibitors. However, venetoclax plus azacitidine is considered the new standard of care for patients who are unfit for intensive chemotherapy. There is an evaluation of triple therapies in patients unfit for intensive chemotherapy going on in clinical trials. So we do need still novel therapies to improve clinical outcomes in patients with newly diagnosed AML unfit for intensive chemotherapy. So I will show you the phase 1b study of first-line magrolimab plus azacitidine in patients with acute myeloid leukemia unfit for intensive chemotherapy. 72 patients with TP53 mutated acute myeloid leukemia were treated with magrolimab priming dose 1 milligrams per kilogram on days 1 and 4, followed by 30 milligrams per kilogram once or biweekly as maintenance. And azacitidine was received at 75 milligrams meters squared, days 1 to 7 of each 28-day cycle. Primary endpoints, safety and tolerability, and efficacy. Patients, the median age was 73 years, and almost all patients had poor risk cytogenetics. Common treatment emergent adverse events included constipation, diarrhea, febrile neutropenia, and nausea. Infusion-related reactions occurred in 22%. 60-day mortality rate was 18%. Complete remission was observed in 33% of patients, and there was some incomplete recovery in 8%, some morphological leukemic free state in 1% of patients, and partial remissions in 5%. The median follow-up was 8 months, and the overall survival was 11 months. 1 year overall survival was 83% for those receiving a stem cell transplantation and 36% for those that did not proceed to stem cell transplantation. This trial is ongoing, so this is just preliminary data. Now, this is the phase 3 randomized double-blind placebo-controlled study to evaluate the efficacy and safety of magrolimab plus venetoclax plus azacitidine in untreated patients unfit for chemotherapy. 432 patients will be enrolled. The control arm is venetoclax plus azacitidine, and the treatment will go on until progression, relapse, loss of clinical benefit, or unacceptable toxicities. Primary endpoint, complete remission, and overall survival. So some patients may benefit from a lower intensity treatment regimen, including those that have abnormal organ function, poor performance status, or other active malignancies and active infections who are ineligible to participate in clinical trials. So these patients were included to receive cladribine on days 1 to 5 and cytarabine 20 milligrams subcutaneous twice daily on days 1 to 10. Patients continued then to receive cladribine plus cytarabine alternating with decitabine on days 1 to 5. The primary endpoint was a 60-day overall survival rate. So the composite complete remission was 58%, and this was highly significant for such a poor outcome group of patients. The overall response rate was 65%, and 19% obtained MRD negativity. The number of patients is very small. The survival outcomes are a median overall survival of 8 months, 60-day survival probability of 81%, 1-year survival probability of 38%. So induction therapy with cladribine plus low-dose cytarabine was effective and well tolerated in patients with newly diagnosed AML unfit for other clinical trials. So this is a phase 3 randomized crossover study to demonstrate decitabine exposure bioequivalence of the oral decitabine and the intravenous decitabine to generate clinical data in patients with acute myeloid leukemia. So patients were randomized to receive either oral decitabine first in cycle 1, intravenous decitabine in cycle 2, and from cycle 3 onwards, oral decitabine, or to receive first intravenous decitabine cycle 1, followed by oral decitabine in the following cycles. The primary endpoint was the area under the curve equivalence over 5 days of dosing. So the equivalence was demonstrated, and it was 100%. Safety data were consistent for the oral decitabine expected for the intravenous. The median follow-up was 8 months, with a median overall survival of 8 months. The key response outcomes were the composite response of 32%, which was expected as would be with decitabine intravenous. So based on preliminary safety data and clinical activity, oral decitabine has the potential to be an alternative to the standard intravenous decitabine regimen. So to summarize, magrolimab plus azacitidine is well tolerated with durable responses in patients with high-risk TP53 mutated newly diagnosed AML unfit for intensive chemotherapy. The study is still ongoing. The other study with magrolimab plus venetoclax plus azacitidine is ongoing. Induction therapy with cladribine plus low-dose cytarabine is effective in those patients that are unfit for other clinical trials. And based on preliminary safety and data and clinical activity, oral decitabine has the potential to be an alternative to the standard intravenous decitabine regimen in newly diagnosed acute myeloid leukemia. Finally, I would like to discuss advances in risk assessment and treatment personalization for patients with high-risk MDS or acute myeloid leukemia, data from the EHA 2022 Congress. So, if we look at the current approach for diagnosing myelodysplastic syndromes, we know about medical history and examination and the importance. Blood and bone marrow assessments are standard, and mutation analysis will include SF3B1, FLT3, WT1, and other mutations. However, there's interest in evaluating the use of circulating tumor DNA to determine minimal residual disease status for patients with myelodysplastic syndromes and acute myeloid leukemia as a non-invasive prognostic biomarker. So I would like to start with a non-interventional study to analyze intrapatient functional heterogeneity of acute myeloid leukemia blasts and to improve clinical response predictions from drug response profiling. 44 patients with newly diagnosed acute myeloid leukemia who underwent intensive induction chemotherapy were sampled at 3 time points, obtaining 180 patient samples, both bone marrow and blood samples. And an ex vivo drug response profiling of 100 distinct drugs or drug combinations was performed and matched with serum cytokine profiling, RNA sequencing, and clinical data. The analyses aim to identify cellular subpopulations whose functional response is predictive of treatment response. Patient samples were obtained at baseline, after first chemotherapy, after second chemotherapy, and an ex vivo drug response screening was obtained with immunofluorescence, automated microscopy, morphological profiling. These samples were included in a drug plate that contained 100 drugs or drug combinations, and a drug response data was generated considering which drugs were able to kill the leukemic cells. The information was combined with patient characteristics. What was found was that there was a highly heterogeneous blast composition across samples. The acute myeloid leukemia blast composition and maturity predicted first-line treatment success. The ex vivo drug screening predicted the clinical response, and the results led to the development of a pan-clonal drug score that was able to evaluate which drug was able to kill the leukemic clones without harming the normal T cell subsets. So this is functional precision medicine that can help guide treatment choice in patients with acute myeloid leukemia. Another study was performed to identify unfavorable prognostic immunophenotypic and molecular genetic markers in patients with myelodysplastic syndromes. 68 patients were evaluated through primary diagnostic complex of MDS performed from bone marrow. So these are the genetic markers identified, and the IPSS-R classification included about half of the patients with high-risk MDS. So a three-state illness-death model was created, starting from diagnosis. At diagnosis, patients that had at least 65% CD71 expression, more than 75% CD13 expression, had a higher probability of transformation. Patients that had less than 50% expression of CD38, more than 50% CD13, and complex aberrations greater than 3 had a higher risk of death. So for those who had transformation, those who had less than 5% expression of CD25, less than 50% CD33 had a higher probability of death. So grouping patients with high-risk myelodysplastic syndromes by immunophenotypic and molecular genetic markers for risk of transformation or death warrants consideration as a new approach for guiding treatment choices. So this is a study to assess the role of circulating tumor DNA as a biomarker for monitoring therapeutic response and clonal evolution in patients with myelodysplastic syndromes and acute myeloid leukemia. This was assessed in 31 cases with MDS or AML, bone marrow next-generation sequencing, and circulating tumor DNA was evaluated at baseline, and then there were at least 2 serial circulating tumor DNA assessments 1 month apart for analysis. Targeted deep sequencing of bone marrow and circulating tumor DNA was performed with a panel of 165 genes. So these methods assess the clinical relevance of dynamic circulating tumor DNA monitoring during treatment. What was shown was that patients that were positive for circulating tumor DNA after treatment had a lower median progression-free survival and median overall survival compared with those that did not have a circulating tumor DNA detection. And this was highly significant. Also, the variant allele frequency, when it was higher, it was considered as prognostically poor for patients that were treated. And these patients had a higher risk for disease progress, for relapse, and for bad clinical response. So the UNIFY study assessed midostaurin plus chemotherapy in patients that did not harbor a FLT3 mutation with newly diagnosed acute myeloid leukemia, and the study was interrupted for futility. However, the prognostic value of minimal residual disease was assessed in this study and was presented at the EHA. Bone marrow and peripheral samples were obtained during the study, and the analysis focused on samples reaching complete remission at the end of induction. So the MRD positive patients, the peripheral blood and the bone marrow correlated in a very strong way. So they were both valuable to predict the lower event-free survival and overall survival. In fact, those that had positive minimal residual disease did fare worse compared to those that did not at 1 year for event-free survival and for overall survival. So results from this analysis support the use of molecular MRD assessment to predict outcomes in patients with AML, both from peripheral and from bone marrow. This is a retrospective chart study to assess treatment intensity and MRD status as prognostic indicators of overall survival and relapse-free survival in patients with newly diagnosed acute myeloid leukemia who achieved a first response. So patients were divided according to the treatment they received, intensive and low intensity. And this MRD status was assessed, and overall survival and relapse-free survival were assessed. So MRD negative patients fared much better than MRD positive patients, independent of the intensity regimen, and the MRD negative patients, the high intensity patients, fared better. But at multivariate analysis, the MRD positivity and the European Leukemia Net adverse risk were the prognostic indicators for overall survival and relapse-free survival. So that MRD negative had similar overall survival and relapse-free survival as patients in the intermediate or adverse categories. So in patients with newly diagnosed AML, MRD status at the time of first response and European Leukemia Net category were strong predictors of outcomes. So finally, a very important report was the new distinction of AML from MDS. Until now, we have considered AML with a cutoff of 20% bone marrow blasts and an MDS excess blast 2 with blast count between 10 and 19%. However, in a recent report, patients who had MDS with excess blast 2 and a WHO-defined AML had similar outcomes: overall survival, event-free survival, and complete remission rates. So now we have a new international consensus classification that has major changes. First of all, the changes to the AML defining blast threshold, where the MDS with excess blast 2 has now disappeared, so that it is now considered acute myeloid leukemia. It will be denominated MDS AML, or it might fall into the new genetically identified entities when it falls within the AML with myelodysplasia-related mutations as an MDS EB2, and the category of AML with myelodysplasia-related changes has now been eliminated. So in summary, intrapatient functional heterogeneity of AML blast was a strong predictor of clinical response to first-line intensive induction chemotherapy in acute myeloid leukemia. Circulating tumor DNA status was a prognostic indicator for disease progression, relapse, clinical response in patients with MDS or AML. We can group patients with high-risk MDS by immunophenotypic and genetic markers for risk of transformation or death. The use of molecular MRD assessment is helpful for predicting outcomes in patients with acute myeloid leukemia. In patients with newly diagnosed acute myeloid leukemia, both the MRD status and the European Leukemia Net adverse risk category at the time of first response were strong predictors of patient outcomes. And importantly, the change in the nomenclature from MDS excess blast 2 to MDS AML may impact treatment approaches in myelodysplastic syndromes and AML in the nearest future. Thank you very much for watching this data summary for higher risk MDS and newly diagnosed acute myeloid leukemia from the EHA Virtual Congress 2022. And I hope it has been useful for you.
Hello, my name is Michael Heuser. I'm a professor of medicine at Hannover Medical School. So for the high-risk MDS patients, there were some interesting abstracts and presentations. And I want to start with the magrolimab presentation that was presented by Dr. Salman. And he gave an update of the study with magrolimab and azacitidine in higher risk MDS patients. As you know, magrolimab is a CD47 antibody that blocks the don't eat me signal. And the complete remission rate was reported with 33% and the objective response rate with 75%. And overall, that appears favorable compared to azacitidine monotherapy. Now, the 2-year overall survival was approximately 50%, and that appeared similar to the azacitidine monotherapy. So therefore, I think it is very important to await the phase 3 trial that compares azacitidine plus magrolimab to azacitidine plus placebo and really see what the benefit is. Definitely already now it seems have a good response rate, but whether it also translates into better survival, we will have to wait. Another interesting study was presented on a PD-1 inhibitor, sintilimab, that was combined with decitabine. The complete response rate was 29%, also higher than what we expect from decitabine alone. And the objective response rate, 62%, also high. But it was interesting and a little bit disappointing that the febrile neutropenia rate was 76%. There were pulmonary infections in 38% of the patients, and 57% of the patients experienced immune-related AEs. So while the response rate is in a favorable range, there's high toxicity, and therefore it's too early to really evaluate the benefit of this treatment. And we were waiting for an update on sabatolimab, the TIM3 antibody, but there was no clinical update, but just the outline of the phase 2 and 3 trials were presented. And we very much look forward to the presentation of data on this TIM3 antibody. TP53 mutated AML is a dreaded disease type, both in MDS and AML. And so far, we don't have really a useful treatment option for these patients besides azacitidine or decitabine. So this question now arises whether it is useful to use venetoclax in combination with hypomethylating agents, and the jury is still out. And therefore, it was interesting to see a systematic review presented at EHA 2022 on TP53 mutated AML, where the published data on P53 mutated AML was presented and compared intensive chemotherapy, patients treated with hypomethylating agents, and hypomethylating agents with venetoclax. And across all regimens, the median overall survival was 6 months, and it shows again how deadly this disease is. There was a trend for better response rate in patients who were treated with HMA plus venetoclax compared to hypomethylating agents alone. But this had no effect on overall survival. So currently, there's no good evidence that the addition of venetoclax to HMA is better. However, there are no randomized studies on that. The subgroups are small, and there's only retrospective data. So currently, I still combine HMA with venetoclax also in TP53 mutated patients. Then Naval Daver presented magrolimab data in TP53 mutated AML patients. This was a phase 1b study with 72 patients. The CR rate was 33%. objective response rate 49%. And the median overall survival was 10.8 months. And this has some promise, although the follow-up is short, even if you compare it with the 6 months reported in the systematic review. So the randomized data also in this combination is eagerly awaited. Yeah, I think this is was the most important data. There's some previous data in the past, and we have to consider how we integrate the impact of the biallelic mutation status of TP53 in our routine diagnostics. And I think that was not greatly discussed at EHA, but it is an important aspect for our future management of these patients. Yeah, currently the standard of treatment in unfit AML patients is azacitidine venetoclax if venetoclax is available. And there were a couple of new suggestions and discussions about emerging treatment combinations. And I think one of the interesting ones is the azacitidine ivosidenib combination in IDH1 mutated AML patients that tripled the survival in comparison to azacitidine plus placebo. It also induced a rapid neutrophil increase, was associated with a low infection rate, and it reduced the transfusion burden, and overall was associated with a 24-month overall survival rate. So this combination is already approved by the FDA and available in the United States, and I hope that this will become available also soon in Europe. Another question, of course, is whether in older patients intensive chemotherapy is better than non-intensive treatment regimens. And Farhad Ravandi and colleagues did a retrospective analysis where they compared patients treated with intensive chemotherapy and non-intensive regimens who were older. And I think what was interesting in this comparison was that the flow MRD negative patients had an equally good relapse-free survival and overall survival, whether they were treated with intensive chemotherapy or venetoclax azacitidine. So once you achieve remission, the outcome is very similar, independent of the initiating treatment. Of course, whether the rate of MRD negativity is higher in one or the other regimens needs to be studied in prospective trials, and that actually is ongoing. Then Dr. Venugopal presented an interesting study for patients who are not eligible for any clinical trial because of an active malignancy, because of high performance status, or of a poor kidney function or other exclusion criteria. And in these patients, they applied cladribine, cytarabine, and then switched that with decitabine. And they actually achieved remarkable results. That was a 68% complete remission rate, a median overall survival of 8.3 months, and an acceptable 60-day mortality of 16%. So I think these patients where we think we don't have options are now have been treated with an interesting combination and have a remarkable remission rate and also a remarkable overall survival. And then another important comparison, I think, was the study by Dr. Geisler, who compared the pharmacokinetics of the oral decitabine, the ASTX727, with the IV decitabine. And this study, as you may know, has been approved already in the United States. And in the study, 89 patients were randomized, and they showed the exact same pharmacokinetics. So the response rate and also the survival was as expected and comparable between decitabine IV or oral decitabine. And this, of course, gives now a new option for patients and gives more convenience in case you want to treat the patient with decitabine. There was a multitude of new data presented on biomarkers and new algorithms. I think the most critical was summarized by Dr. Papa Emmanuel, and that was the long-awaited molecular IPSS, the IPSS-M. And that will become very useful and I think is already practiced now by many of us, as it was published just a week ago. And then Dr. Döhner presented the new ICC and ELN guidelines, and these will be also very relevant for our daily practice in the management of AML patients. I want to quickly highlight here that the MDS EB2 category will be replaced in the future by the category MDS/AML. Also, secondary AML will be defined genetically in a subset of patients who do not have a history of MDS or anti-cancer therapy. And the allelic ratio of FLT3-ITD will be abandoned, and patients with FLT3-ITD and NPM1 mutations will be classified as intermediate risk patients, independent of the allelic ratio. So these are important changes. And then the abstract was presented by Dr. Sun from Taiwan, and they presented the data that secondary type AML mutations confer a poor prognosis in de novo acute myeloid leukemia. And this was the basis also for the decision to integrate that in the new classification of ELN. Also, an abstract was presented from the Harmony group by Dr. Hernandez Sanchez, and they looked at 1,000 NPM1 mutated AML patients, and they introduced a new classification based on the co-mutations that are found. And if you make a score with FLT3-ITD, with a ratio with TP53 and DNMT3A, you can stratify these NPM1 mutated patients according to the ELN categories that are known. So I also think that this will be very helpful. And another study from the Nordic group presented by Dr. Tobiasson showed that also in MDS patients who undergo allogeneic transplantation, molecular MRD is a strong prognostic factor if you monitor it after transplantation. So that will be also a very useful tool. And finally, Dr. Tidi presented NGS MRD data from a large study with FLT3 wild-type patients, and their MRD was confirmed as a prognostic marker, and also the cutoff of 0.1% for NGS MRD was confirmed. Thus, we have a multitude of new information that we need to integrate into our daily practice.
Hello, my name is Dr. Yishai Ofran, and I'm the head of hematology at the Sha'arei Tzedek Medical Center in Jerusalem, and I'm chairing the Israeli Leukemia group for the last 5 years. So I think that there are two main messages from EHA 2022. First, there are two large studies that demonstrated the result of azacitidine as a single drug. One is a British one with 932 patients, and one is a meta-analysis of 16 studies. And the bottom line is that azacitidine alone is not a sufficient therapy. Having said that, there are plenty of additional drugs that are being studied in this context. There are some Czech group that demonstrate the experience with additional of venetoclax. There are some groups that describe the addition of anti-PD-1, sitanilimab, and maybe the most impressive data are the addition of magrolimab, an anti-CD47 antibody that a phase 1 study with 95 patients of this was reported. And additional drug that should be mentioned is tamibrotin, which they don't have really data right now, but they are initiating a phase 3 data. And I think that their result in the phase 2 data are very impressive. So the main issue with high-risk MDS is that azacitidine alone will probably no longer will be sufficient as a treatment for MDS. And many drugs are competing between who should be the substitution for, not the substitution, the addition to MDS, to azacitidine in this setup. So P53 mutation is a challenge in AML and MDS. And in recent years, there are plenty of research done regarding how to deal with patients with P53 mutations. And unfortunately, many intensive and aggressive agents fail to deal with those patients. Even results with allogeneic bone marrow transplant are inferior when patients present with P53 mutation. It is a challenge across all kinds of malignancies, but especially in MDS and AML, it's patients with P53 mutation are of higher risk, and as I just mentioned, many agents fail to improve result with P53 mutation. In EHA 2020, I think one of the promising agents that we're reporting was the phase 1 study reported of azacitidine and magrolimab. Magrolimab is the anti-CD47 antibody which plays as a check inhibitor, and the application of magrolimab allows the immune system of the patient to work against the MDS cells. And what they reported is that of the 95 patients who participated in this study, which significant portion of them were P53 mutated, the response rate in P53 mutated patient was 40%. And 40% with P53 mutation is a very high response rate. Actually, it was identical to the response rate of non-P53 mutation, and this, in my view, is a very good start for approach that may be promising to patients with this high risk. Until recent years, treatment of AML and very high-risk MDS was based only on intensive chemotherapy. Fortunately, in the last few years, lower intensity treatment is coming in, and basically the most popular one is the Vidaza venetoclax regimen. And but with the years that we use those lower intensity regimens, we know that even they are good in achieving remission, disease tend to relapse and come back. And EHA 2022 is full of paper which try to deal with this high relapse rate. And I think that the main message that comes from EHA is that transplant after lower intensity treatment is feasible and not only doable, but improve significantly the survival of patients. We have some very nice piece. One of them is a prospective study that compared intensive regimen to, I don't know if I can call it non-lower intensity, but the decitabine venetoclax, the decitabine for 10 days compared to intensive chemotherapy. This is non-chemotherapy regimen, but it's 10 days of decitabine is maybe lower intensity than intensive therapy, but it's really not so lower intensity regimen. But the bottom line is that if we're speaking about remission rate, you can achieve the same remission rate with 10 days of cytarabine and venetoclax compared to intensive chemotherapy. Having said that, more patients on the intensive regimen went into transplant, and that's bringing me back to the main message. You can treat patients with lower intensity treatment, and it could be that in the years to follow, we will see more and more patients getting induction of lower intensity. But even if you achieved remission, transplant remain the thing that patient benefit the most of it. Thank you. So the message with of biomarkers in EHA 2022 is maybe the most important message in AML and MDS, and even maybe in hematology as general. And the message is that not all patients are alike. Not all the AML are alike, and not all the higher risk MDS are alike. We need to start with the work of molecular classification of MDS, and there are many, many works. For maybe some of them are high volume, all MDS included, that generated molecular-based score for prognosis on MDS. This should be added to the knowledge that there are many, many targeted therapy that are being tested in MDS, and among them, there are studies in IDH inhibitors, FLT3 inhibitors, and a drug that I think was mentioning, Tamibra 10, which is targeting RARA overexpression, which is very frequent in MDS. So first of all, molecular classification is not only for prognosis matter, but also for treatment decision. More than that, there are some papers in EHA 2022 that subdivided what we know as distinguished group. So MDS with aberration in chromosome 5, which we know we treat with lenalidomide. Also, there are subclassification that is molecularly being subclassified. So the taking home message from EHA 2022 is that it's not no more enough just to do cytogenetics and classify MDS by that. You need to do cytogenetics and a wide panel of next generation sequencing, and only with that you are ready to treat or to decide how to treat your patient with MDS.
My name is Esther Oliva, and I'm a hematologist at the Grande Ospedale Metropolitano in Reggio Calabria, Italy. Though venetoclax and azacitidine combination is still under evaluation for safety and toxicity profile, I believe that it is the most promising combination requiring tailored individualized dosing. Furthermore, it may serve as the backbone for future triplet therapy, for instance, with magrolimab that has shown promising efficacy, and we're still awaiting confirmation of the sabatolimab trials. The prognostic importance of TP53 mutation has been highlighted at the EHA with the International Classification Consensus of Acute Myeloid Leukemia by identifying acute myeloid leukemia with TP53 mutation as a new genetically identified identity with a particularly poor prognosis that requires special attention. Therapeutic trial results focusing on response in TP53 mutated cases show the effort in improving outcomes in such patients. For example, magrolimab results stratified by TP53 mutation or concentrated only on TP53 mutated patients. So lower intensity treatment aims at prolonging remission, thus improving survival and quality of life. Though azacitidine and venetoclax combination is the standard of care, a balance between adverse events and remissions must be taken into account when evaluating novel treatments. It is still too early to predict which of the trial drug combinations be the winner, but the addition of magrolimab seems to not confer additional toxicity to the standard of care combination, with possible beneficial effects in TP53 mutated patients. And previous reports on sabatolimab combination seem very promising if responses be confirmed as favorable. Circulating tumor DNA seems very promising as a non-invasive procedure, especially for monitoring in unfit patients. Furthermore, though it seems complex, pharmacoscopic evaluation of leukemic cells within drug panels may be important to assign treatment at diagnosis or at relapse.